Hello everyone, I'm Vanessa Reagans, aka The Anatomy Nerd, here with Dr. Nancy Gardner, and she is going to be presenting to us this afternoon, and I'm so excited to have her on here. Thank you so much for being here. So I wanted to share a little bit about how I met Dr. Gardner, and it was actually during my yoga teacher training program, and we went to an Ayurveda school to tour it. And then Dr. Gardner presented to us, and it was phenomenal. I was so excited to learn about the thermography screenings, and I'm really excited for her to share more about that with all of you today. So, Dr. Nancy Gardner.
Okay, so, well, I have a PhD in clinical research and a master's in nutrition, and I'm board certified at Auburn University to do medical thermography. And have pretty much been doing that for about 28 years. So I have a pretty good background in that, and also was a surgical nurse. So for my patients who are diagnosed, I, for free, go through every procedure and support them in that. So I'm going to do a presentation today about thermography, the basics of it, and comparing it to mammograms so you can make better choices. So. Thank you.
You're very welcome.
So my question is mammograms actually failing us as a tool because women are refusing to do mammograms. They don't want to traumatize their breasts with the harmful compression and the radiation just to see if they're healthy. The error rate is not worth the damage that it does. There's a 60% accuracy rate for that's for postmenopausal women who have soft breasts that the breasts can be compressed down, little pancakes. and then it's a 40% accuracy rate in dense breast women. So they keep telling them to come back in for more radiation, which has a cumulative effect, meaning it can cause breast cancer. And then out of the 80% false positive, this is with mammograms, 80% of the time they're asking to do procedures, and those procedures are invasive, and they can go in and spread things outside the duct that normally would have just stayed there maybe your entire lifetime and not have turned into breast cancer. So, yeah, no es bueno.
Yes.
I was very lucky to teach a 17-week course in preventing diseases for women at UC Berkeley. This was quite a few years ago. But Dr. John Goffman joined us for a seminar on preventing breast cancer because he had just written this book after, he's the head of radiology at UC Berkeley, and after 5 years of research came up with that it's this book, and on the front cover of it he put, it's our estimation that 3/4 of the current annual incident of breast cancer in the United States is being caused from earlier ionizing radiation, primarily from medical sources. And when he published that, they actually fired him because they wanted him to do the research, but they didn't want him to tell everybody that mammograms are causing breast cancer. So it's well documented. There we go. If you're going to compare a mammogram to thermography, I went for the error rate because it's easier to see the difference. So mammograms have a 40% error rate. That's in postmenopausal women, and a 60% error rate in younger women with denser breasts. Thermograms have a 9% error rate. That's for both false positive and negative, and it is not affected by breast density. This is really important, especially for women with augmentation, because there's no compression that can rupture the appliance. And then for young women and women who are pregnant that you want to avoid radiation, there's absolutely no radiation with thermography. So, did I get that right?
Yes. There you go.
Okay. This is one of my favorite slides in the whole presentation, dispel the mystery about breast cancer. There are two factors in the development of breast cancer. One is atypical cells dividing with dysfunctional DNA, and the second is the blood supply feeding that, called neoangiogenesis. I'm going to take the next slide, which teaches you a little more about what causes the atypical cells. 40% of us have DCIS. This comes from post-mortem statistics. That's research that's been done on biopsies of people who, whatever, died of car wrecks or whatever, all different kinds of things, not just breast cancer. So the things that cause those atypical cells is too much X-rays, nuclear fallout, toxins, all of those things destroy DNA and RNA and make your cells start reproducing with dysfunctional DNA. Stress causes the immune system to be compromised. Lack of sleep, where your body's not regenerating your cells. Poor diet, use of drugs and alcohol that compromise your liver. Those compromise the amount of natural killer cells to go out and gobble up all the garbage in your body. The cause of neoangiogenesis, that's the blood supply that sets up to feed a tumor, is very simply too much hormones, estrogen predominantly. Estrogens feed neoangiogenesis. So where do we get estrogens? You can get it from birth control pills, fertility drugs, postmenopausal hormone replacement therapy. Almost all of those are made out of estradiol. The doctors will tell you estradiol doesn't hurt you. It doesn't cause breast cancer, but it can convert to estrone, and estrone does cause neoangiogenesis. So if you're taking birth control or fertility drugs, you can't get pregnant and then they take fertility drugs, you should definitely take Indolplex with DIM. And this is made out of the cruciferous vegetable, broccoli sprouts predominantly, and it blocks the pathways from estradiol from converting to estrone. So it keeps you from getting breast cancer. And a lot of young women, they're in their 20s and 30s, they're going to be taking this a lot. So it's real important for them to, and you can get it at any health food store, DIM, or Indol 3-carbinol, either one of those. Another thing that can cause angiogenesis is smashing your breast. Sometimes women will come in with angiogenesis just because they got in a car wreck and their seatbelts was across the front of them, and and that should, after you've healed, go away. But if you add more things to it, it can increase it. So. And then, of course, the last thing I want to mention, even though doctors will tell you that there's no damage or trauma done from biopsies, but if you have DCIS, ductal carcinoma in situ, in the duct, and you poke a hole in it to biopsy it, you spread it. And they keep telling everybody that's not true, but I don't believe it. And so why do they rush in and want to take it out when it's only a precancerous condition? So. Anyway, so try to avoid as much unnecessary poking around in there in surgeries if you don't need them.
Makes sense.
Yeah, it's important. So this is coming out in a different format, but I'm going to talk to you a little bit about thermography. Actually, I'm going to show you what thermography sees. Thermal imaging is using an infrared camera. There is no radiation. We're looking at your body's heat. So this is a TH1, totally benign condition. You can see the little gauge or the key on the left side of the picture. And at the top where it's white and gold, that's hot. So see up by her neck and her jugular, it's much hotter. And then down at the bottom where it's the lower parts of her breast are purple, and that's cold. So she has fibrous tissue in there that doesn't have a lot of blood supply to it. Points 1 and 2 are pointing out hot features that look like little lightning bolts in a night sky, and those are vascular features, and hers are very symmetric, totally normal, totally benign. Let's go to the next one. Oops. This is a TH2. She also has a benign condition. She doesn't have as much fibrous tissue. But she's a little bit more vascularized, and that's why it goes up into the 2 category. So it's still benign and very symmetric. And I wanted you to get a feel for that because if you look later on, the next one, you'll see. And this is the first sign of an asymmetric pattern, and that comes out as a TH3 or an atypical, meaning it's not the way it should be, but it doesn't have a high risk. It's like less than 10% risk of malignancy. And it could just be a little low-grade inflammation, a mammary duct infection. So if you look at the breast on the right side of the screen, that's her normal breast. And the breast on the left side of the screen it's too hot. It's got lots of blood supply coming there. So what I would do with a patient like this is put them on a protocol to get that to go away, and using Indoplex and some other things to boost up their immune system. And usually they come back with it gone.
Nice.
80% of my patients that come in with something atypical like this, if they actually do what I say, not everybody does, but they come back with it gone. So sometimes they'll do some of what I say and it's gone away a little bit, but not completely, and then I can talk them into it after that. And they say, see, you're getting results, but you're not doing the whole pictures or the whole thing. So here's someone with a little bit more serious feature. She's got two features, and this puts it up into the TH4 category. It's got a big vascular feature. It looks kind of like a W on its side there. And then the whole breast has hyperthermia. And I put that in specifically because that is one of the criteria for it moving into a higher category, is a whole breast hyperthermia. This could be a mammary duct infection. Like I said, it doesn't necessarily mean breast cancer, but I'm going to show you someone with a very advanced case of breast cancer next, and then you can see. So this is only about 65 to 85% risk, and then this is up to 96% risk.
Wow, that's a big difference.
Yeah, it really is. I hope I put the next picture in here too. Let's see. Yes, good. I'm glad I put this in because the picture in the left view is of her left breast, and you can see that's her normal breast. So you can see how much more this is in 2 quadrants. It's a very complex vascular feature setting up to feed a tumor. She's got hyperthermia of 2 quadrants, and it's 1.4 degrees hotter than the hottest point on the other side. So that puts it up into the category of a 96% risk factor. And that all of these came from a study in Marseille, France, at the Pasteur Institute, where they followed 3,000 women for 5 years and then just took pictures. They didn't put them on protocols like I do to see if you can get it to turn around. They just wanted to see what the readings were. And then they went back with the women who had breast cancer and looked at all their reports and came up with these criteria, and that's why they can tell you what a percentage of risk factor you have with the specific features. So it's a very in-depth study. Not everybody does thermography the same. A lot of the people out there practicing now, when I first started, there wasn't anybody else out there. There was maybe 3 or 4 other doctors that were practicing, and they were the doctors that were on the board of directors that certified me, and they were breast surgeons and really some top-notch guys. Now a whole bunch of young girls are out there doing thermography screenings, but they really are basically photographers. They are trained to take pictures. They don't know anything they have no medical background. So you want someone with a good medical background, somebody who's going to take the time and do a skilled palpation and feel your breast and look at your breast, because some kinds of breast cancer don't have lumps. So you may not have anything suspicious. The procedures I use, I actually go in and check the temperature, like I showed you on these pictures of the features compared to the hottest point of the other side, so I can look at them. So you want someone who's going to follow standardized medical thermology and do the skilled palpation. The report should include a comprehensive view of the both breasts, so you can compare it to the next one. And I also think it's really important that they have a phone consultation to go over their reports. And most people they aren't the ones who did the report, whereas I'm doing the report, so I know what I'm looking at.
Right.
So they send it out to somebody else, and then it comes back, and they really don't know how to interpret the study. And then, like, I also do free counseling for anybody who's got further testing that they need to be done. So I'm going to show you another picture. This is a woman who had ductal carcinoma in situ. She was biopsied. She went on my protocol. The picture on the left is before she did the protocol. And you can see when I do the reports how I go in and within 100th of a degree see what temperature her breast that has something suspicious compared to the breast on the other side, the temperatures and how simple the features are. So you can really see it. The next picture over, the picture on the right, is her after a 17-month program. Most people within 3 to 6 months have improved. She had taken hormones for 26 years, synthetic hormones, so I think that's why she took longer to get it to turn away. But you can see it's not only is it completely gone, but because I take the time to go in on these pictures and tell the temperatures, you can see that the feature on the other breast is actually hotter than the features of concern. So we know that it's completely gone. So it's kind of an interesting way to look at it, but I think it's really important. And whenever I do a report, I always have the last time you came in and the second set of pictures with all those points marked so that you can, it makes you feel good when you know you did what I said and it made it go away and you can see that it's gone and
You can see the proof.
yeah, and it
important.
empowers you to know what's going on with your breast. You don't just go into a doctor for a mammogram and they either say, oh, there's something suspicious, you have to come back in. And they don't ever explain to you
It's
what
this
it
fear.
is. Very fear-driven, and that's just unacceptable to me.
Totally.
There we go. I just added a few other things because I do full body thermography also. Some of these come from case studies and some of them are just investigative. I feel like Sherlock Holmes. But the first one is looking at the fellow's eyes, and we're going to see the level of stenosis of the carotid artery. The next one over is varicose veins. The following one over on the right hand on the top is a woman who has augmentation that had been in for 36 years, and they started decomposing into her lymph nodes and her liver's inflamed. So these are all things. And when I did her report, I wrote in it that the doctors need to remove the augmentation, and then that way her insurance would cover it. So I put it in a way that she could get lymphoma from it.
Oh,
I
wow.
kind of exaggerate a little bit. Not really, but there's a good potential it can. But
Yeah.
I can't guarantee that's going to happen, but I just made them have to pay for having this augmentation removed. The picture down below is, I'd say the formatting is not as good as I'd like it to be. It's kind of, I lost root canal, but there's a little squiggly line coming from her chin down, and that's a root canal that's infected. The next picture over is a fellow with the thyroid gland, and he's got an inflammation of his thyroid gland. The next picture over is somebody whose lymphatic system is really, really lit up.
Wow.
And honestly, it's probably because she's eating food she's allergic to. Probably eating gluten and, it's that kind of thing. I've got one more to show you some more full body. That one at the top is, you can see, he's got diverticulitis in his hepatic flexure. So you can see what that looks like. The next person over has whole body thrombophlebitis, which is varicose veins, but she's got it all over her whole body.
Wow.
The first time I saw that, I was like, I don't know what that is. I've never seen anything like that before where somebody's lit up. So I called my friend, one of my doctor friends, and he's really great at all this investigative stuff. I call it my Sherlock Holmes stuff. And he told me it's from her medication she's doing for her heart medication, was making her vascular system look like this. So the next one over is a picture of a woman with congenital heart disease. So you can see her heart and how the heart will show up, the blood supply to the heart.
Wow.
The next one down on the bottom left is someone whose thyroid is so dysfunctional that her emission levels are way, way too low. And when I told this patient, I've never seen anybody as cold as you are. I think your thyroid's not functioning. She said, I don't have a thyroid. I had it removed. So she had thyroid cancer, and they removed her thyroid. So you can see that the emission levels, the amount of heat, is really affected by things like that. The next picture over the one in the center is a dysbiotic condition of her gut. So her liver is lit up, and then you can see what happens with the dysbiotic condition of the gut is you get a leaky gut, and the pores in the gut open up and let things leak into the bloodstream that shouldn't be, causing inflammation throughout your body. So what we're looking at there is points 1 through 3 is her liver is lit up.
Wow.
Which is, it's not producing enough, it's producing bile probably, but it's not releasing it into the small intestine to change it from an acid stomach to an alkaline small intestine and slow down the decomposition and help close up those pores so only things that are well digested should make it through. So all around her gut, you're seeing the lymphatic system lit up, somewhat like the other person that I showed you with the lymph. And then the last picture is a woman who is estrogen dominant. And I wanted you to see this because it's really an important view of a lot of women who've taken too much hormones. This is what they're going to look like. And that really makes them predisposed to breast cancer. So I would give them something like calcium D-glucarate and let them calm down that extra estrogen and clean it out, help their liver clean it out a little faster. Calcium D-glucarate boosts phase 2 of the liver function. So that really helps. Let's see, where did I?
And there are protocols for each of these?
Oh, yeah.
Okay.
That's the one thing about a full body. You get a 40-minute phone consultation. I go over the results, and I put together a protocol addressing each and everything I see. This is only some of what I see. There's lots of other things that come up. It just depends on the person. But then during the phone call, I give you a whole protocol, individualized protocol, and then I send that to you in an email so that you have everything that you need to address. Sometimes it's so much information they can't remember it all, you know.
I still have my email.
Do you?
Oh yeah, I have it starred.
Yeah.
Oh yes, I review it often.
Yeah, you can work on the things that are most important and come back and work on a little bit more later.
Exactly.
Let me see if I... Okay. So there's just a little bit more about the 28 years that I've been doing this. I've taught at San Francisco State in the holistic program, UC Berkeley, that's all women's health, and then the University of Hawaii at Hilo, and I taught my whole health education series, which we may view later on.
Yes,
So
that'd be awesome.
that's basically it.
That's fantastic. Very cool. Well, Dr. Gardner, I have a couple questions for
Okay.
you. So, how often should somebody come in for their thermography screening?
I think that annual, once
Okay.
a year. If somebody comes in year after year and they're getting a benign reading and they skip a year, it's not a big deal. But if somebody's got something they're monitoring, it's really important to have the check-in to make sure that it's not gotten worse and that it is actually improving from the protocol, or maybe the protocol needs to be increased. Some part of it needs to be increased according to what I'm seeing.
Okay.
So,
Awesome. And what are the options that people can choose, the offerings that you have for your thermography screenings? Can you go over that one more time, like what you offer? You do the breast exam and
yeah. Well, so the
body?
breast exam, you fill out an intake form. You come into the room and you undress on the top and just put your hands up so that everything can cool off. And then I'll take your pictures. I take frontal, left and right view, 45 degrees and 90 degrees. And then I put your hands on ice and do a second set of pictures. And then I'll do a manual breast exam and note that on the intake form you filled out. Then you'll get a report within a week, and then we'll have a phone consultation and go over that together. And I charge $245 for that. The full body scan is much more in depth. I do include the breasts with it, but I'm taking pictures from head to toe, so you have to be a naked baby in the room because I can't do it with your clothes on. That's all there is to it. But from head to toe, front and back, and then I'll pull those pictures off and put them on your report. So each one you're getting a report. There's a 2-page report with the breasts, and your pictures are in that. And with the full body, there's all the pictures will have notes, and then I'll go down and write what I see in each picture and what that means. Then we have a phone consultation, go over that, and that's where I put together the protocols.
Perfect, perfect. So that was really awesome for me. I chose to do the full screen. I was going in just for a breast thermography screening, but I chose to do the full body based on everything that kind of has occurred in my family history. So based on my health and things that have come up with my family, I wanted to just make sure that everything was good to go. I still have that email. I still have the pictures.
Good.
Yes, I reflect on it often. So where do you like to have people contact you?
Okay, well, they can call me, or they can go to my website, which is right on there, healthybreasts.info, not .com. There's a menu that says timeline of events, and it'll show all the locations all over the Bay Area that I screen. So I'm everywhere from Sacramento to Fresno. Today I was screening in San Francisco, but I go all the way to Santa Cruz, Marin, East Bay. So that's
and Hawaii.
And Hawaii. You may have to come see me in Hawaii.
You can see her in Hawaii.
Yeah. You need to go. You just have to make a trip.
Yeah,
but on the Big Island and Kauai.
Awesome.
So.
Very cool. Well, this has been so informative. I was so grateful that you took the time to come down here and share this with everybody. I can't wait to get this all up and sent out to everybody. So thank you so much for your time today, Dr. Gardner.
You're welcome.
All right, everybody. Thank you so much for tuning in, whether it was live or you're watching this recording. Follow Dr. Nancy Gardner and check out her website at healthybreast.info. I'm Vanessa Reagans, aka The Anatomy Nerd. Thank you so much for tuning in. Bye, everyone.